Welcome to the Jali Podcast. I'm your host, Melyssa Barrett. This podcast is for those who are interested in the conversation around equity, diversity, and inclusion. Each week, I'll be interviewing a guest who has something special to share or is actively part of building solutions in the space. Let's get started. Welcome to the Jali Podcast. Today's conversation is one that really matters because it's about people, communities, and the systems that shape opportunity long before most of us ever realize it. I'm joined by Dr. Eugene Manly, a scholar and equity advocate whose work focuses on understanding how inequities show up in real life and what it actually takes to change them. Through his research and his work with the Scheck Foundation, Dr. Manly works alongside communities to turn data, lived experience, and advocacy into action that creates lasting impact. This isn't just a conversation about systems, it's about people, accountability, and what equity looks like when it's done with, not for, communities. Let's jump in. I truly do appreciate you coming back for round two with Dr. Eugene Manly Jr. So I'm excited to have you, and I'm so grateful because there seems like there's so much we can talk about. And this area, I think, is when we start talking about equity, it's such an area that people I think there's a lot of people that understand what the inequities are, but really to try and transition to equity has become a lot more challenging, shall I say, in the last year.
Yes.
Um,
That's an
so,
understatement.
yes, I'm trying to be nice without
Yes.
getting on my
Oh,
soapbox.
I know.
But so I wanted to kind of just start off. Maybe you can talk a little bit about some of your advocacy work, because I know we talked a little bit about the Scheck Foundation and the mission and impact that you're having there. And I'm interested to understand where you think you're seeing, resistance and the accountability when we talk about equity in this area. And what kind of change do you think we really need to be focusing
Well, I think it's like you were trying to play safe here.
on?
I
You don't
think
have to play safe though.
a lot of the, resistance is part of it is this has kind of always been where we have been as a country. Even
Mhm.
though people like to believe we made all this progress, but fundamentally, the country was founded on the fact that they wanted slaves. The initial, creation of the police force with the slave dogs, and then, go through Jim Crow that you couldn't read or write. So they never wanted us here, or they only wanted us free, and they didn't want us educated. So it's just now that this is an environment where it's fashionable to really be anti DEI, whatever that means. It is just much more challenging to do the work, and I really empathize for a lot of the universities that have really had to change how they write their grants, try to cleanse the equity, but it's kind of interesting because how do you say you are going to do ovarian cancer or breast cancer work without saying women? So this is one of the broader issues where you're getting things pushed down, but if you don't change how you write or frame stuff, you won't get funded. But then fundamentally, how much is what you're writing to get funded going to change? I know that sounds like I just talked in a circle, but
Well, it just goes to show you how illogical some of this actually is, right? Because
so
it's like, okay, so I want to help serve women, but I don't want to say I'm serving women. But But
Yep.
we are
And
women.
s-
So,
and so I really empathize with a lot of my academic colleagues that have really drastically had to change how they write their grants if they want to stay funded. I know some pretty big nonprofits that working in underserved communities that have lost a lot of money. I know a couple of organizations that have folded because they have lost money. And some, because especially those that are embedded within universities, that it's just especially when you're within a university, it's like on the one hand, you have the university resources, but then at the same token, if you can't say A, B, C, D, and E, then how do you do your work? So I think it's going to require really people, as we always do, trying to think outside of the box to get the work done. Now, admittedly, those that are still heavily relying on government funding have a much harder road to toe than those that aren't with government funding. Like me, I have no government funding, so I don't think they care about me. So, but also at the same time, we have a lot of organizations that used to support a lot of diverse serving orgs, and then they're sort of taking a backseat, and the funding is just not going to orgs working in these groups because there may be fear of pushback, and then they don't want to be under the microscope. But this is sort of part leadership and part human, or losing touch with what the real purpose of humanity is supposed to be at an esoteric level. A lot of times when you're building these relationships, it's still under the guise of what the company's still supporting. And then sometimes you still get a lot of people that do not communicate with you. I probably shouldn't say that publicly, but and then at some point you have to stop chasing those. Like what is the return on my time if I'm gonna beg and plead you to talk to me when I did this and try to do this in academic? Said this is not how I operate. So this is good. Anyway, you just have to make your own path and then try to find the people that believe and support what you do, and then hopefully get enough momentum and support to then be the change you want, as opposed to needing others to help implement the change that is necessary.
no, I think that's actually, a valid component because I think a lot of times we forget how valuable our time actually is. And to be
Yes.
able
Yes.
to, create a match in a shorter period of time actually relieves a lot of stress, a lot of, just, running in circles. And so I think a lot of times, we keep trying to push for something. And I always feel like if there's too much resistance, maybe take a step back and figure out if you are running into a wall and you need to turn and go through the door. You know what I mean? So,
Yep. Or make your own door.
yes, exactly. It's an interesting conundrum these days. So, when you think of artificial intelligence in this space, what are you seeing in terms of how it's impacting the space? I mean, obviously, AI is doing wonderful things. And on the other hand, there are all these other things like privacy and, other components that maybe people don't necessarily talk about as much. So, how are you seeing AI in your world?
Okay. So before I answer that question, we talk about opening doors. We all just need our own Kool-Aid man. That's what we need. And oh yeah. And
Oh
so just
yeah,
and so,
I remember that guy.
so that aside, now let me get back onto the question at hand. So your question was about AI, I guess more so in healthcare, health equity.
Yes.
So this is a thing where, so at a fundamental level, I foresee AI as really using data to look at trends, variances, and distributions, and then combining that data and then trying to predict how things will go, act, or behave. That's root level what AI is. Now, the problem is when you apply it to medical care, it's really, the question is who is designing the programs or implementations, what are the controls, what is the base population that is being used, are there people from underserved, underrepresented communities in the program design, in the staff, in the assessment, in the analysis, and they are not represented, more than likely it is not going to work at all, or they're going to have these blind spots. And they're going to believe we have a solution, unlike for who. And this is sort of corporate 101. It's often who is at the table is not the one that need the interventions. So, like, we can give you some examples of where AI is great. So, one example is there's this algorithm called Sybil, SYBIL. It is used by the University of Illinois Cancer Center, I want to say Mass General Hospital, and a couple other institutions. And it's a free downloadable algorithm that was used to test whether low dose CT scans of patients could predict lung cancer risk 5 years, at least up to 5 years later. And this algorithm was designed to, um, based on the National Lung Cancer Screening Trial data, which roughly led to the recommendations that people with a 20 pack year of smoking, of cigarette smoking, be eligible for screening because it was able to detect cancer early. But in that data set, the majority of people were not diverse at all. That being said, the algorithm was able to show with pretty high confidence that it could predict in a scan from up to 5 years before if a person could have lung cancer 5 years later, just based on the scan. And then, so, you have a non-diverse set, which is like, okay, that's not great, that's norm. But then what they did is they validated this set with the University of Illinois Cancer Center, which is a FQHC, or a federally qualified health center
Mm-hmm.
in Chicago, which has a very diverse population of Black and Hispanic patients. And they were still able to show very good ability to predict lung cancer from a scan up to 4 years in advance. And typically, when you get low dose CT, you usually get a scan once a year, at
Mm-hmm.
least for 3 years. And then they also validated this in a South Korean data set. Now, completely different populations, but they were also able to show that you could predict lung cancer in a scan as up to 4 to 5 years early. And that is great because then that becomes a tool that can help with, looking at lung architecture and seeing what might lead to, might say, hey, this is an indicator they might have lung cancer. And now they're working to try to expand this to work in other populations that aren't eligible for screening. So, like firefighters, people possibly with radon, in radon high areas, people that live near areas of high forest fires. These are things that are also lung cancer risk factors, so they don't make you eligible for screening. And that's what you call what's looking like a great win for AI. But then you have things we could talk about, the pulse oximeters and not being able to, really detect oxidation in Black scanners effectively. We could talk about an example someone else just used recently about, someone was saying they had this algorithm that could look at mammography and tell you breast cancer risk. And then someone said, well, what is your population? And it was mainly Caucasian women. And then the person said, well, that Black women have higher risk of breast cancer, and that can be shown in mammography. And the person was asked, well, so how are you going to get this? Oh, no, well, that's not in our data set. So they just dismissed the question, which is what normally happens when you don't understand the population with the disease and you don't do your due diligence to understand all the populations at risk, and then you use your majority population as your baseline, then we have people that are excluded, and then this stuff is not going to work. But we've seen this time and time and again with technologies that's come in and it's the end all be all. They get widely implemented, and it's like, oh, this won't work in this instance. So it's not new or unique.
Right. No, those are great examples. And I love the fact that people are finally able to use some of the FQHCs as a resource,
Yes.
because I think they've had kind of this strange stigma sometimes, but there's such an opportunity to utilize our FQHCs in a more robust way. And so I just think it's fabulous when people reference it's like, hey, there's this population over here that can really be accessed through some great opportunities. So
And I want to say I'll give UIC credit because they have some of the most diverse, at least lung cancer trials in the country, but they're really good with their community engagement office and reaching out to people, seeing if they don't make an appointment, why they didn't make an appointment, if they can get it rescheduled. And they try to also work to bring them in on weekends if it's necessary. So that is that part of meeting people where they are. You can't just go 9 to 5 and say someone is working 2, 3 jobs or being a caregiver. Like they can't do stuff during a week. So having that flexibility to work around your community, but also having people to speak different languages that benefit them is one of those ways you really build trust and trustworthiness.
well, and you were talking about like, because now we have a little bit more access to our own files, our own medical files, most of the time, or at least a version of them. When I think about artificial intelligence, I was on a call earlier this year and they were talking about how the doctors are actually asking if they can record it for AI. I'm not exactly sure how they're using it. um, maybe they're just using it to summarize the notes, but I feel like there's, this kind of component where people don't necessarily know what their information is being used for, and the privacy around it, because there's a lot of AI that's just open AI.
I think you have to be careful about the open AI because you don't really control the information. I also do know that some doctors do, and there is software that does it, that will help them summarize meetings with patients. That in of itself is not bad. It allows them to get the notes written faster because it's voice to text. And so it puts it in the chart and then they can make edits on the fly because otherwise they have to spend then their evening writing in handles. If they're seeing 20, 30 patients a day, they'll never get through. So that is one of the great instances of an AI really helping care, specifically for those that are primary care providers who don't have resources. You talked about people and keeping their data. This is a big issue. There's a term called interoperability,
Mhm.
and this is the biggest challenge in healthcare now. Uh, yes, you have control of your data, but in essence, the healthcare system you're in also controls that data. So there's been a push now for more interoperability, so people can actually control all their data and try to have it in one spot. That is still slowly growing, but the problem is if you go to one system for your podiatrist and you go to another healthcare system for your primary care, they can't necessarily see the notes. And that's what I'm so you may have systems you can, but then you don't have it all in one space. And so that is actually quite challenging and annoying. At least you have access, but then you have to, okay, I have the password for this, and then I have to give them access to this. And so, yeah, so that's why people are trying to push for more interoperability, but you should be able to own all of your data without having to go through 20 steps just to get it.
Right. And be able to pull it back when you need to, right?
Exactly.
So then, I mean, let's kind of look ahead to like some of your biggest concerns about when you think about health equity, and maybe you could talk about what are some of the things that give you hope. Let's turn it to the positive. What gives you hope when you're thinking about, the future of equity and health equity and the work that you're doing?
Here's the thing, as a people, we're very resilient. So we always have adapted to environments that have not necessarily
Welcome to
enriched our lives,
right.
is the terminology that I will use. But we've always found a way to make it happened, because I just think it's just built in the DNA that we've, acquired over the years. So even though there's all this pushback and pullback, at the end of the day, these communities still need information and resources. So it is great to see that some orgs are still trying to do the work. But what that also means is that means we all also have to work on diversifying our revenue streams and other ways of making sure we stay afloat and pay our bills. And that may mean side gigs or hustling more than you want to, because it's just hard to really do straight health equity. It's not that the work is, yes, the work is hard, but getting funding for the work is what's harder, not the work. The work is always going to be hard, but the thing that keeps us going is knowing that some of us that have knowledge and information realize that it has to get out and disseminated to the people that need it most, because they're the ones that are often the most excluded at all points in the research and medical system.
Yeah, no, that's for sure. Let's pause for a moment. We'll be right back. Are there myths out there that you would love to see retired?
There are some myths. We in lung cancer in particular, we have a lot of stigma. A lot of this arose from the anti-smoking campaigns of like the 80s, where you can even combine it with the war on drugs. You think about the eggs. This is drugs. This is your brain on drugs. Any questions? Things you remember.
I do
But
remember that.
you're like, does your brain look like an egg? Like, really? Um, and so let me get back to being serious. Uh, but in lung cancer, there's a lot of stigma, and it's one of the few cancers where, because of all the heavy messaging and the graphic, and which is one hand great to increase awareness, it unfortunately makes people think that only those with lung cancer, I mean, only those with the history of smoking get lung cancer. And while smoking is one of the leading causes of lung cancer, it is not the only cause. But what this means is that anytime someone gets lung cancer, you don't get any empathy. You don't really get a lot of support. You get people saying, well, you shouldn't have smoked and you deserve to get it. And it's like, that's not really the case. Like, my father was a chronic smoker. And I mean, he was out of the house when I was 3, but I always knew where he was. And I think just because being around him, I had chronic asthma and all the allergies. But even as a kid, I'd never sat there and said, just because you have a history of smoking, you get lung cancer. I might have been quite a Rudite, probably more than I needed to be, but it just was never something I thought about. But that being said, so many people get victim blamed, and then they're afraid to tell their family because they don't want to be judged. And then the biggest fear with a cancer diagnosis is like, are you going to live? Are you going to survive? How are you going to pay for stuff? And so, yeah, the biggest issue is that lung cancer is not just due to history of smoking. Other risk factors include, the second leading cause is radon exposure, indoor cooking modules, like air pollution, like forest fires, job exposures, like simply firefighters. So there are multiple other risk factors in play. But then there's also a population that have lung cancer that don't have any history of smoking. Like Asian female with no history of smoking have some of the higher lung cancer rates, and we still don't know why.
Oh, wow.
Just, yep, they have lung cancer. We still don't know why. There's a couple of groups trying to understand what is driving lung cancer in these populations. So that is sort of lung cancer. But the other thing I want to dispel is that, we have this whole thing. So we have a saying in the lung cancer space, anyone with lungs can get lung cancer. And that is still very much true. And so if anyone has it, you really have to treat them with dignity and respect and empathy. because if someone gets breast cancer or colon, and that everyone's, oh, I'm so sorry, and how can we help you? But then it's just a person with lung cancer that seems to be fighting an uphill battle, whether they've had a history of smoking or not. And that doesn't mean that we should, you know, make a difference in how we talk, or even if they have history of smoking. Because unfortunately, well, for lack of, unfortunately, I don't want to say either that caveat. Basically, the majority of the survivors are those that do not have a history of smoking, and they end up becoming the advocates. And so, what's happened is that a lot of our advocates don't have a history of smoking. They're the one doing all the speaking, so it makes it look like lung cancer is not a disease of those that are smoking, but the people that really have the higher risk are not present because they often feel ostracized. Because everyone's like, "Well, I didn't have a history of smoking and I got it," and I'm like, "Think you're kind of it's not to Jim. It's like it's misdirecting the survivorship story."
Yeah. It's almost like you're like it's a different type of victim equity, I guess.
Yes,
It,
that would be.
and stories make a difference. When you're telling your story, somebody who smoked versus somebody who didn't, probably very different stories.
Yep, exactly. And the other thing, which in Black communities, which many of us don't know, uh, a lot of people smoke menthol or and the other ones, and they be like, "Oh, this is better." That's a myth. The other thing, tobacco is already highly addictive on its own. And then when you combine it with menthol and other flavoring, which is kind of sweet, it masks the searing heat of smoke when you're inhaling it. So people that have mentholated cigarettes end up thinking it's better because they don't feel as bad, but no, it's just as bad, if not worse. And the problem is it's harder to break because now you already have something addictive with something that's sweet on top of it. And
Mm.
like I said, that menthol cools the lungs as it goes in. So people mistakenly believe it's better and safer. It is not. It is much worse. And the third myth I'd like to dismiss is that, we're seeing lower rates of people consuming tobacco. That doesn't mean we've done and made the progress we think. That just means everyone is switching over to vaping. And people think, oh, well, this is better and cooler. And I'm like, this is as bad as cigarettes are. Vaping is even worse because you don't know what is in those things. They don't list all the products. Some of these things that are in here were only supposed to be ingested, not inhaled. You don't know how they behave differently. You're taking volatile compounds that you're taking directly inside. And this is already on top of the numerous carcinogens that are already in tobacco. So it is much, much worse for people. And then they vape so much more. And they think it's safer. So now you're starting to see a lot more children. Not, I don't have a number. You're seeing a lot more people in hospital with collapsed lungs, diseased lungs. We're seeing more popcorn lung. So I don't usually say things in certitude as a scientist. I say give it about 10 more years or so, and we'll probably start seeing a lot more lung cancer in younger people solely due to vaping.
Oh, wow. Well, that's not good news.
So that's three myths. Did I
Yeah.
do three myths? Sorry,
Yeah.
that was a long answer.
No,
So
no, those are good though, because I think, a lot of times we think about certain things and, you do. I mean, I know normally when you think about blood cancer, probably the first thing you think of is people smoking. It's good to hear a lot of those other myths, because even knowing that people can get lung cancer without even being around smoke, or, having it in their genetics or I mean, there's so many things that we know more about. And then there's a lot of things we still don't know and we're still trying to figure out. So it's awesome for you to talk about that. Is there like one action you think people should take, um, when you're thinking about, your academic language and the values. And, you talked about humanity, like what's human versus, like treating people like they aren't human as opposed to they're a specific thing and we should treat that, kind of victim shamed, I guess, in some ways. Are there certain actions that you would recommend people take when it comes to, like how they take care of themselves, how they make sure that they are advocating for their own health equity?
Yes. If we think of in advocating for your health, you have to understand your disease and condition, and you have to understand how to advocate and navigate the healthcare system. And when you are not familiar with this, it can be very daunting and challenging because anytime you call insurance or a doctor, you always get put on hold, and then you deal with the bot. Why are you calling? I don't want to talk to you, bot. And then you say, why are you calling? I'm like, one day I almost threw my phone across my apartment. Said, just give me an agent. Just agent. Just I said screaming agent, which is, I mean, it's not unheard of me to scream, but it was that day I was very frustrated. So I can't believe I'm admitting this. You sort of have to, understand how to read your medical records. I think that we touched on this in the other session about the medical racism. I think one thing people underestimate is the ability to read your medical records or have someone that can read them in real time and try to explain all that jargon that's in there. Like I know how to read it, but you really want to read your doctor's notes and any notes about any procedure just to be on the safe side. Because if it's in the chart and it's not caught, then it's just say, well, this is what it is, and this is when it was written. Like I said, I learned that from my own surgery. And mind you, I've just never been just so disrespected and disregarded. And it was because they assume, you're poor and on Medicaid, so you're not of value. So I want people to know, one, you are all important. You deserve to get equitable care and treatment. If you would like your providers to treat you like they would treat their family members, but that unfortunately does not always happen. So that's why I said you want to make sure you have someone that can help you read your records and understand it. You're within your right to ask questions. You're within your right to ask for second opinions. You can also, when you feel you are being lied or disrespected or treated horribly, you have the right to complain to the hospital system if it's a hospital. You have the right to complain to your insurance. You have the right to complain to governing bodies. You have to understand the context, but you have to make sure you understand everything about your situation in case and that you have documentation of it all.
Wow, that's a lot.
Yes, that was a simple version, but there's also broader, depending on, you don't have to just do this in lung cancer. There are also other groups that teach citizen scientist programs to teach you how to advocate for, work in your community, to advocate for clinical trials, trying to get people to serve on these different advisory panels to ensure that the communities that are underrepresented are accounted for. So there are other ways to, participate and make sure you're heard. And I know at least some major cancer centers often have community engagement offices, and they often still try to do community events. So that's a way, and then try to find your local groups that are doing things related to your cancer or a disease. It doesn't have to just be cancer.
Yeah. No, that's awesome. Because I think a lot of times, I mean, I've had personally, both my father had colon cancer, my husband had colon cancer, my dad also had lymphoma, and so, but we found out he actually passed away because the colon cancer that they did, they used that mesh uh to hold your intestines in or whatever, and
I don't know.
the mesh is what actually ended up killing him. It just flaked away like tissue paper. He had cancer for like 17 years, but then it's like the thing they installed to fix the first cancer is what ended up kind of taking him over the edge, which, you
Um,
know, there's so many things going on and there's so much technology, but a lot of times you don't even know how it's going to impact you years later. So,
yep. And as you mentioned colon cancer, I want people to know that even though people don't like to talk about it, you all should be getting your colon cancer
Colonoscopy.
screening. I
Yes.
want to say after 40,
45.
45.
Yes.
Uh, it's important and critical. I don't care what you think about, taking an enema and then sitting there laying on the table. And then they, going, doing a magic school bus, but hey, just got to be done. So, let them go on that journey and find those polyps and get them out. And that'll save lives. But the biggest challenge right now is we're seeing a lot of people show up with colon cancer that are younger than the guidelines. So that we still don't know why. And that maybe that is partially due to processed foods over here, um, all the extra antibiotics in our feed. We do a terrible job of keeping our food supply as natural as we can, and
Hmm.
that doesn't mean a vegan thing. It just means we have too many additives and stuff just to try to preserve it on the shelf longer, and that's not necessarily good. Like I did my colon thing, I was about a year and a half late. I just couldn't get there. But and then they found some polyps and they said, well, nope, you're fine, but you had two that were precancerous. Not that they were cancer, they were gonna become precancerous. So now as opposed to having to go back in 5 or 10, I have to go back next year or the year after. So so it's just important to do that and just get it done, and then just you don't want that to linger just because you're afraid. And I know there's a lot of stigma with that, but that's things we have to have real discussions about.
Yeah, for sure. Get your colonoscopy.
Yep.
For sure. And, a lot of, I mean, we could go on and on talking about different cancers and different, health equity. It's like, but really, I think what you're saying is you really have to become your own advocate. And if you don't know how to do that, get somebody to help you. Um,
Yes.
and
Yes.
and there you talked about citizen advocacy work that's being done in the community, identifying different areas, whether it be cancer centers or other agencies or organizations that are working in the space that you are looking for. I think those are all really phenomenal because I think there's so many nonprofits that are filling the gap. And I look at Scheck Foundation, I love the fact that you're bringing together a variety of stakeholders. It's not just the doctors and practitioners, but you actually have patients in the room advocating and really understanding all of this information, which I think is so important. It's like we have to show up for ourselves.
I think that's very true and very critical. You know, the biggest challenge for patients is one, often not being in a space, not being seen or heard. And then we typically only have just a patient event or just a researcher event or just a clinician. Well, if you're only talking to your peers, that's not really, synergizing or building camaraderie. So you have to get the people to communicate across their platforms, especially the goal is to get the patients to, feel better, be better, advocate, and then have them understand who is working on their behalf. So that's why we put our stuff together the way that we have, because we always have silos, but the problem is if you work in silos, nothing moves.
Yeah, no, that's so true. Well, time just is flying by. And I think, we could probably go on and on, but is there something you want to end with to kind of round it out? You're doing so many different things in the community and around, with the Scheck Foundation. I will give you the last word.
I will say, just at the end of the day, when you go to the clinic, just know you deserve to be treated with respect and dignity. And if you're not, know how to advocate and where to report. But also, you can find us, on the website check.org, especially for groups that want workshops, leadership training. Please reach out info@check.org. We have, where we just made our speakers page. So we are ready and geared up for that. So anyone that wants me to talk, I'm happy to do it.
And spell Scheck again, just so that people know how it's spelled.
S SCHEQ. So it's like Shrek is pronounced. Scheck, but it's like Shrek, but without the R. But the long version of the name is STEM and Cancer Health Equity. So that's how Scheck came to being.
Yes, I love it. But I know every time I go, I'm like, wait, how's it spelled again? You threw that C in there for me. But no, I just really appreciate all the work that you're doing. And I cannot thank you enough for, kind of sitting down with me and talking about some of the wonderful things you're doing. I love to celebrate people that are doing great work in the world. And so I appreciate you, Dr. Manly, and wish you well for sure.
Thank you so much. It's always a pleasure to talk to you. I just think you're doing some phenomenal work and trying to bring some great voices to the forefront that are really trying to impact our communities.
Thank you so much. Thanks for joining me on the Jali Podcast. Please subscribe so you won't miss an episode. See you next week.